Good afternoon, everyone. I'm really delighted on this. I don't know if it's autumnal or winter or slightly deciding what it's going to be afternoon, to be part of a webinar discussion on the role of management in leading and supporting innovation and improvement. My name is Neno Suji. I can't see many of you. I hope all of you can see and hear us well. And we've got some amazing people here today. So I'm really delighted to have this conversation for so many reasons. One, I think that at this moment in time, when a lot of what we're focused on is immediate and right in front of us, there seems to be less space, less discussion for the really important, interesting, exciting, and needed conversations on innovation and improvement. Also, because when we talk about our managers, and we don't talk about middle managers, we talk about core managers, because this is the lifeblood of the NHS. These are the people who are central and critical for us being able to do, to deliver, and to move forward. These are people we should cherish, and yet the narrative in the media is more pejorative. So this is a really interesting space, and I'm struck by the fact that over 600 people have registered to listen to this webinar, which tells me something about the hunger for us to be having this conversation. I'm particularly excited because this is an opportunity for us to showcase a lot of what we do in the NHS is fixing and sorting the things that are wrong. Here's an opportunity for us to stop and to celebrate some amazing opportunities of where this has been done well. And I hope that you too will bring your curiosity and your constructive challenge and the questions that will be posed, because I'd really love this to be interactive as far as we reasonably can. So please join me in welcoming Okas Zielinski, who's going to start us off in our presentations today.
Thank you very much, Nina. Could you please forward in the slides again? So very quickly, we're just going to start with a bit of a scene setting first with a few of my colleagues from the Health Foundation and the University of York. We'll be discussing some of the case studies of management supporting innovation improvement with our wonderful guests from different trusts, followed by a bit of a Q&A and a moderated discussion and reflections at the end. Next slide, please. So to start with, my colleague Brian Jones and I will be talking about the role of management in healthcare and healthcare innovation and improvement. Next slide, please. And again, next slide. The importance of healthcare management is increasingly being recognized by policymakers. And indeed, the recent key policy documents have recognized it as the cornerstone of innovation improvement. For example, the 10-year health plan has highlighted management as key to NHS becoming an innovation powerhouse, which needs to be strengthened and improved. Then the DASH review suggested that investing in management could make a significant difference to the care quality, as currently relatively little support goes to the day-to-day management and improvement of care. And finally, the draft NHS Leadership Management Framework identifies leading the mindset of improvement and innovation as a key standard to delivering across health and care. It is critical in driving continuous improvement and innovation and supporting others through change. Next slide, please. However, despite all of the talk in the policy level documents, there are still lots of challenges facing management and managers in the NHS. For starters, the NHS is likely to be undermanaged. Manager workforce in the NHS constitutes approximately 3% of the overall workforce, compared with approximately 9% of the overall workforce in the UK. NHS management is also commonly seen as an example of an extreme job. It is common for managers to be operating in the constant firefighting mode, attending to and providing quick fixes to things like deteriorating infrastructure, flooding operating theatres, clinical capacity challenges, issues with staff shortages, and financial constraints, leaves very little headroom for focusing on the much desired innovation and improvement work. These challenges are on the background of shortage of management capabilities within the NHS as a whole, which has been highlighted by the Darcy report, and the current level of management capability in the NHS is lower than in 2011. Furthermore, according to the survey by CMI, approximately 6 out of 10 NHS managers face challenges which stop them from performing their job effectively. With all of these, there is also a tendency to blame managers for problems within the NHS, such as, for example, the long waiting list or excessive bureaucratic relationships between different organizations. Next slide, please. Throughout our engagements with NHS managers and previous stakeholder events, we have, however, seen numerous examples of NHS managers doing an excellent job in leading and supporting innovation and improvement. And this is despite all of the obstacles that are being faced on a daily basis and of the operational challenges. And while managers do contribute to effective running of the service, the ways in which they do it and the capabilities needed for delivering remain unclear. And this is where our research that we commissioned to the University of York is coming in. What we're hoping to do through this research is to highlight and shine light on the role of management in innovation improvement and what enables it at the organizational and policy level. And the goal is to provide evidence based on how the NHS management can be strengthened and help to deliver on ambitions of the 10-year plan. And I'm going to hand over to my colleague Brian Jones now.
Thank you, Łukasz, and afternoon, everyone. Can I have the next slide, please? Right. So I'm going to just talk to you briefly about some of the learning around managers' role in driving an innovation improvement, learning from Health Foundation in-house research and some of the research that we've funded. And I'm going to focus my comments on 3 particular areas which I think managers are playing an especially important role. So next slide, please. So the first of them is around facilitating information flow, both within and across organizations. And we think that's kind of crucial given that high-performing, improvement-led organizations in any industry, not just in healthcare, are underpinned by a culture of learning and effective knowledge exchange processes and systems. And so there are particular behaviors which are particularly important around managers' work. So one of them is around acting as a lever in change, so influencing both your peers, those above and below them. Secondly, there's something around bridging structural holes in organizations. So managers, by speaking the language of both leadership and frontline team, create that kind of connection within organizations around change. Thirdly, there's something around maximizing the flow of information about the purpose implementation of innovation. So what it is, why it matters, what people can learn from it, how it's going to affect their jobs, how it's going to improve their jobs. So that kind of building the kind of will, building engagement around change, really important role there for core managers. And then finally on this, there's this issue around fostering connections, trust, and shared values. Because if there isn't trust within teams, there isn't that kind of sense of shared purpose, which comes from relationships and comes from the ability to build those relationships, then change can't take root. So that really important role about fostering connections and trust is a key role of managers. So next slide, please. So the second particularly kind of key thing I want to talk about in terms of managers is carving out the space for change. So, this is vital because change can't happen just at the margins, undertaken by enthusiasts in their lunch breaks, after work. It has to be prioritized and valued by organizations, and managers have a key role here. Critically, there's something around ensuring that operational balance between business and usual and innovation improvement, because so often when in times of pressure, innovation improvement can get squeezed into the margins. So vital we provide that space for both to flourish. And managers are really important for that. Secondly, there's something around kind of creating creative solutions to change, around resource restrictions, resistance to change, bringing people on side, thinking about kind of workarounds, thinking about how you kind of implement change through their kind of their sort of improvisation and creative skills. Crucially, also, there's that issue around permission and confidence to do things differently. Because we know in a lot of organizations, people think about the risks of doing something. So creating that enabling space where people feel comfortable and empowered to drive change, managers are key to that. And essentially, there's something there around deferring to experience, not position. So when we're thinking about change, it's drawing on people's kind of specific skills, basis, what they know, rather than rather than their position. That's particularly critical. Finally, on this, it's providing that space for collaboration and co-production. So working with service users, patients, to sort of co-produce change and providing that space for collaboration. The final area I want to talk about, so next slide, please, is around building capability and capacity for change. Again, so important. So it's about thinking about not just kind of operational skills, it's about what we call, what my colleague Ian will talk about around dynamic capabilities, that ability to kind of think to those change-related skills. And so providing the space for people to take time off, to go off and learn and train, and permission to actually work on change whilst they're in their day jobs is crucial. So that kind of fostering skills, coaching teams to lead innovation, providing training, encouraging people at all points, recognizing the kind of resilience you need to do this kind of work, and especially when things don't go according to plan, is crucial. Secondly, around ensuring impact. You have to create that capacity to measure and evaluate change, and also understand when the issues which kind of demand attention. So where do you identify the problems? How do you kind of put those forward? How do you then measure change as it happens? Thirdly, aligning coordination, those discrete interventions, because we know unless those kind of particular interventions that happen in organizations are part of a strategic or aligned with strategic priorities, then they can easily kind of run out of steam. And also around something around avoiding duplication, avoiding that kind of real invention when people are doing the same things in different parts of the organization. So again, managers are key to making sure we don't have to do that. And then finally, it's just a sort of recognition of the very diverse skill set that managers bring to this. So it's not just their critical thinking and analytic skills, it's their intuition, it's their political nous to kind of navigate complex worlds, and then their tactical flexibility to foster positive change. So there are three areas which, from the Health Foundation perspective, are particularly important. So I'll now hand over to Ian from University of York, who's going to talk about the research that Lukash has already mentioned.
Thank you for that great introduction, Brian. Perhaps just move over to the next slide, please. And the next one. So what I'm going to do briefly now is just give you a flavor of the research that we are conducting. This is a 2-year project, as Brian mentioned, commissioned by the Health Foundation. The official title, Capacity and Capability in NHS Trusts and System Level Partnerships. And here is our team, most of whom are attending this webinar today, including Lukash, who's been assisting us with the fieldwork, and Case Kirsten, and in the bottom right-hand corner there, Joanne Reeve from the Hull York Medical Centre. So the next slide, please. So the project has 4 primary aims, and I'll report back on how we're doing with this and some of the ideas that we started to generate from it. So first of all, we are trying to get a fix on the current level of management capability in NHS trusts in England. And of course, this is easier said than done. The official statistics indicate that possibly around 2% of the workforce are formally managers, although the NHSE rightly calculate that the number of people involved in managing, either as hybrids or accidental managers, is far greater. Possibly 150,000 people have some kind of management roles, including band 6s. We want to then examine whether this current capacity is sufficient to meet the demands facing the NHS currently and over the next decade, including the 10-year plan. There's a lot of talk about undermanaged services in the NHS. In fact, the Institute for Governance last year claimed that the NHS was dangerously undermanaged. We want to explore that concern. Thirdly, and principally, we're interested in getting a fix on the, if you like, the capability of managers and management in NHS trusts, with a particular interest in the question of innovation and improvement. Matthew Taylor used the phrase split screen thinking recently to differentiate between effective management that keeps the show on the road and also management that helps project forward to thinking about how we can improve and transform the service, and in particular, the innovation and spread of new technologies, which is one of the primary goals of this government. And lastly, we want to get a fix on the, if you like, the sufficiency of that workforce, its effectiveness, and what can be done to sustain management and improve it over the next decade. So next slide, please. Very briefly, in terms of a stock take, the project contains 6 main work packages, and you can see there, the first is a lit review. The second was preparatory work, trying to make sure that we get an adequate, purposeful sample of trusts, including 7 in our study. Both of those packages are completed. The third and main work package we're still involved in now is the main data collection. That is in progress, but we have made good progress. And I think at this point in time, that's 80% complete. Once we've analyzed that data, in the next couple of months, we're going to engage in a national consultation to try and get feedback and people's impressions of the findings that we've produced, and that will happen early next year, as will an exploratory study looking at system-level bodies, the ICSs, assuming that they still exist, and the production and dissemination of our final report. Next slide, please. So I'm just going to take you through what we're doing with work package 3, which, as I mentioned, is the main data collection phase of the research. And then I'll talk a little bit about our theoretical thinking on that we're going to use to frame the findings. So we're adopting what's called a comparative case study design, looking at 7 trusts, NHS trusts as study sites, drawing on qualitative interviews, observation notes where possible, documentary and administrative data sources. We're hoping to use some of the model hospital data, but that's not been confirmed yet. Of the 7 study sites, we've spent a lot of time in work package 2 trying to make sure that we have the right sample. So in the end, we decided to look at 3 acute non-specialist trusts, 2 mental health trusts, and 2 ambulance trusts, because we have strong expertise in the team focusing on paramedics and emergency services, and we wanted to utilize that and also get a feel for the range of management practices and experiences across the whole sector. Our purposeful sample was designed to try and select trusts that are at different stages in terms of their performance, and we used a basket of measures to try and rank trusts in terms of their performance. We also wanted to get an initial fix on their management capacity. So using formal administrative data sources, we differentiated between trusts that appeared to have fewer and more managers. We also try to account for differences in geography, deprivation index, urban coastal differences. In each case, we're interviewing approximately 15 people in senior and middle manager and some operational management roles, clinical and non-clinical. And we're also looking at specific examples of innovation. So in each trust, we're looking at 4 generic innovation types, including what we call administrative process innovations. That would include perhaps redesign of pathways of care systems, technological innovations, which speaks for itself, governance innovations, which are usually led by central functions such as HR, estates, or IT, and new service innovations, the creation of completely new services. Now, the nature of those innovations differ between the trusts, but we've tried to categorize them in this sort of generic way to ensure comparability. Importantly, for each of these cases, we're looking not just at the adoption of innovations, but critically their implementation and their sustainability. So what does it take in terms of management effort and tactics and strategies, not just to adopt a new idea, but to put it into practice, to embed it into practice in a sustainable way. We're also looking at innovations that vary in terms of their scope, scale. Some are more localized than others. And in terms of key drivers, are they led by the top in terms of responding to policy initiatives, or are they bottom-up innovations? And of course, in terms of their progress, some of the innovations we're looking at are completed, others are still ongoing. Final slide, please. Now, I'm not going to talk too much about this, you'll be glad to hear, but we've spent a lot of time over the last couple of months trying to get our heads around a way of theorizing this process. So that's a way of theorizing what managers do in relation to innovation, implementation, and innovation adoption. Now, this framework comes from a perspective called dynamic capabilities. So this comes from a different field of management research, from what's called strategy research, and a particular area of strategy called the resource-based view. And essentially what it highlights is the need to focus on management routines. So not just the skills and capabilities and practices of individual managers or teams of managers, but the routines that exist in an organization that foster or hinder effective innovation. My apologies. Sorry, I should have turned off my phone. And we make a distinction here between what are called ordinary capabilities and dynamic capabilities. Now, ordinary capabilities are the routines in an organization around communication, people management, financial control, what have you. Whereas dynamic capabilities are higher order capabilities that allow organizations to evolve those routines in a way that helps them to innovate and change. Now, the arrow to performance outcomes should probably have a question mark on it, because what we're saying is that the existence of these routines does not guarantee performance outcomes. It's essentially contingent. So organizations may have these capabilities, but may not use them. On the bottom side, we're saying that management, or what we call dynamic management capabilities, are critical for enacting this process. And on the left-hand side, the antecedents, we differentiate between 3 levels of antecedents: individual, team, organizational, environmental. And these are all of the things that will shape the ability of managers to create and enact dynamic capabilities that fuel performance outcomes, that fuel innovation. Now, you're probably thinking that this is a little bit vague and ill thought out, but at this stage, it's just a framework that we are in the process of developing and which we will apply to the research going forward. Now, I think I've spoken enough here, and apologies for that interruption. I'm now going to turn over to my colleague, Mark Hayward. Thank you.
Thanks, Ian. Next slide, please. Fantastic, thank you. So thank you, everyone. Can we go back? There you go. Actually, we'll go forward, please. One. There we go. No, back again. So that's the one. So we could pause there for a sec. Thank you. And so thank you, Ian. Thank you, everyone. My name is Mark. I work in MPFT, Midlands Partnership Foundation Trust. And within the trust, I work within our project and programme management team. So we support the organisation to deliver high-level, significant change projects and programmes across MPFT, sometimes working with some of our system partners, UH&M North Staffordshire combined as well. So for people who aren't aware of MPFT and what we do, we are a provider of mental health and community services, predominantly within the West Midlands area. But as you can see on that map, we deliver services across the entirety of the UK. We're a holder of university trust status, which was awarded by Keele University in 2023. And we've recently been announced as second in the non-acute trust league tables, just 0.1 point off the top spot there. Not that I'm competitive, but I think what we can see there is we deliver a range of services across the UK, and we are one of the leading organisations to provide those types of services. If we could go on to the next slide, please. So what I wanted to Thank you. What I wanted to share with everyone today was a project that we've been working on within our team to try and develop and build on the project management capability and capacity within MPFT. So the basis and kind of foundation of our approach is kind of summarised in this quote, which I actually found in a Project Management for Dummies book a couple of years ago. But I thought it summarised really what we kind of see and kind of view project management as, and that is a critical skill for many and not just a career choice for a few. So what that means to me and my colleagues is that while we are working project management day to day, running those high level significant projects, we recognise that across MPFT, and probably the wider NHS, there are people out there who are spotting things that could be improved and developed and enhanced, people who want to be innovative, but not everyone has that critical skill to be able to enact that change. So my view, and it's my colleagues' view, that project management is a critical skill for anyone and not just a career choice for a few people. Because whoever you are, and whatever role you're in, the likelihood is you might want to make something better or improve something. By having the project management approach and the methodology and the mindset that project management will instill in people, you'll be more likely to be able to achieve those things. So that's our kind of basis and foundation. What we set out to do, next slide, thank you, is to unravel, enlighten, and demystify project and program management. So the reason we did that was effectively when we're working on projects and programs, we need to bring people together from across MPFT and across different teams and services. And what we frequently find is those individuals may not have had the chance to work on projects and programs in the past, particularly with clinical and medical colleagues who might be experts in their particular clinical areas, but when it comes to project and program management, they may not have had a chance to work on projects and may not have had that type of skill set within their professional development. What we frequently found was bringing these people together, they could quickly develop the perception that project management would be quite burdensome and bureaucratic, particularly when we start talking about highlight reports, change reports, mandates, briefs, those sorts of things. So what we felt was by unraveling, enlightening, and demystifying project and program management, we were able to quickly develop the capability and effectiveness of people contributing to large-scale projects. But really importantly for us is to give people the knowledge, skills, and confidence when leading small-scale projects and programs within their teams, services, and wards. Next slide, please. So the way in which we did that was to develop a series of modules which brought together the knowledge and skills and expertise of our team and service and directorate to create a powerful, purposeful and practical learning experience. We did that under an internal brand of Blue Sky Training. We ran those introduction to project management, fundamentals of project management training courses, and we've done that over now for around about 2 years or so. We've trained roughly around about 600 staff across MPFT. One of the things we've tried to do as much as possible is to capture feedback and interrogate that feedback so we can learn where there might be additional opportunities. And one of the things we found was that while people valued the opportunity to gain a theory when it came to project management, what they felt that was missing was a supportive environment to provide the support for them when they go to try and apply that theory. And so from that feedback, that's where a community of practice concept was developed. And we actually launched that in February this year. So now from that training, colleagues can go into our community practice where they receive hints, tips, best practice, project management drop-in sessions. So they're running a project of any scale or size and they've got a problem, they can come to our team and we will help them through that. We also bring in external speakers to share project management learning and training. But again, through capturing knowledge and feedback from those people and interrogating that, one of the things we found was a bit of a gap. So we would give people the theory, we would give people a supportive environment, but we wouldn't always involve people in running the projects to be able to see that theory being applied. And that's where that kind of third point on the slide comes from, that final quote. So teach me and I forget, so tell me and I forget, teach me and I remember, and involve me and I learn. So what we've done is we've identified then a need and an opportunity for shadowing and mentoring. And that's what we're doing now through our community of practice that we have done for the last couple of weeks. So we've got 600 people who have been through the project management training, around about 300 in our community of practice, and around about 20 to 30 who are actively shadowing projects and programs across MPFT. And what we've done is we've created a series of training modules now, which give people that knowledge, skills and confidence. And now we're giving them the opportunity to see that theory being applied. So what effectively we've been able to do is to grow that capability and capacity within MPFT to support change and innovation. But we've also grown the capability and capacity within our team by employing people through the project management community of practice to grow our capacity to be able to deliver more projects and programs. Next slide, please. So again, constantly monitoring and improving is one of the things we aim to do. And by keeping track of the impact, we know we've been having significant impact on colleagues who have come on our training. So we've got some examples here with people from our specialist falls team, our children's and young people team, and our library and knowledge service have come on the training, they've joined our community of practice, and they've been able to employ and deploy and utilize some of those tools and techniques and the theory that we've given them to be more effective. So whether that's running pilots to execute new preventative falls programs, or involving children and young people in a CYP participation team, or rolling out our libraries and knowledge services, people are reporting to us they're more effective when running change and innovation projects. Next slide, please. But as well as keeping track of that impact on teams and services, we're also really keen to understand the personal impact. I won't go through the details of each individual quote here, but what I will highlight is the variation in job description here. So what you can see is people from pretty much any background, any level of seniority from across MPFT who've been on our training course are reporting significant personal impacts. They're now more effective, more able to achieve the changes they want within their team and service to improve the way they're operating, but also to improve the experience that staff and patients are getting. And that's something that we've found universally across all staff who have been on the training so far. Next slide, please. So just to conclude on the lessons learned. So what we've done is we've grown the project management capability and capacity to support change and innovation. We've provided staff with the knowledge, skills, confidence, tools and techniques, that supportive community of practice, and the opportunities to seek shadowing and mentoring to develop their skills. And what we found though, specifically, is that even a small amount of knowledge can support and make a big difference. So things like measurable benefits, smart objectives, project plans, which might seem small things to myself from a project management background, are things that are new and can be quite impactful for people who haven't previously had that kind of thinking and mindset before. A focus on continuous improvement from what we're doing to evaluate and identify potential opportunities to further grow our support for staff has been really impactful. And that final thing, which I'll finish on then, is that change and innovation can originate anywhere within an organisation, but for ideas to really grow and be impactful, they need to be supported. And through what we've done within MPFT, that's what we're doing. We're providing that support for people across the organisation at any level to be able to take an idea, develop it, and then implement it within their team or service. And it's something which I think has been really successful for us. So I'd be happy to take any questions, I think, probably after this, or if anyone wants to get in touch to learn more about that, please feel free to contact me. I think I'm handing over to Sarah next.
Lovely. Thank you, Mark. Next slide, please. And next slide, please. I'm Sarah Wellings. I'm from Mid and South Essex NHS Foundation Trust. We're one of the largest NHS trusts in England, with over 17,000 staff, serving a population of more than 1.2 million. The My Staff app emerged during a pivotal moment, a merger, restructure, and the launch of our digital strategy. This created an opportunity to review how the document control team operated, and also identify where digital transformation could make the biggest impact. The Trust Innovation team provided the catalyst for a unique and very successful development partnership with a third-party developer, a collaboration that has now spanned 5 years to date. The original concept came directly from staff, and we piloted the app in maternity and emergency departments with digital midwives. That successful pilot laid the foundation for trust-wide adoption. Next slide, please. This slide shows an overview of the functions available within the app to help staff on the front line and in administrative roles to find policies, guidelines, and patient information leaflets quickly and easily in any care setting. In addition, to be aware of changes to these documents through automated notification and to send digital patient information leaflets to patients. Next slide, please. And this second slide shows an overview of the functions available within the app to provide real-time reporting of compliance for all staff and document control administrators. In addition, this key information supports document owners with proactive management of their document portfolio through timely review of documents involving the risk assessment of each document as a management tool. This then ensures that high-risk documents are reviewed as a priority, for example, where a change in local guidance is required as a result of an update to national guidance. Finally, the digital document lifecycle enables document owners to import or create new documents within the app environment to include local approval, document ratification, and publication processes. Next slide, please. So My Staff app was developed in collaboration with our trust to digitise and transform what was once a manual, time-consuming task. It directly addresses critical challenges in document management and staff efficiency, contributing to improved patient care and substantial time savings. We reduced document retrieval time from 20 minutes to under 30 seconds, a dramatic improvement in frontline productivity. With over 17,000 users and more than 1,600 documents, the app has significantly boosted staff engagement and confidence. It aligns with key recommendations from the 2024 DASI report supporting digital transformation, data-driven decision-making, and a shift from treating sickness to preventing it. We hope to inspire other trusts to adopt similar solutions and show how close collaboration between developers and clinicians lead to real-world impact. Next slide, please. So the impact has been substantial. We've seen full staff engagement, major time savings, and improved compliance. Patients now receive consistent digital information, improving understanding and experience. We've also reduced our environmental footprint and earned a Gold Sustainability Award. These outcomes were made possible by freeing up managerial capacity and embedding feedback and audit cycles into the app's evolution. Next slide, please. And leadership was key to the success of My Staff app, not just in terms of delivery, but how we led. Managers led phased rollouts, supported training, and created peer networks to embed learning. We empowered document owners to manage their own portfolios, and as back-end processes became more efficient, governance teams shifted from reactive oversight to strategic improvement. I also want to highlight the leadership values that underpin this work. I believe in leading with heart and soul, nurturing emotional energy, kindness, and gratitude, while building healthy relationships and empowering others. I focus on growing the team, providing opportunities, feedback, empathy, and respect for each person's needs. As I invest in developing both soft and hard skills, mastering self-management, decision-making, and technical capability, these three elements, heart, team, and competencies, only work when combined. Heart and team foster engagement, but without skills, success is limited. Heart and skills drive personal growth, but without team focus, performance suffers. Team and skills drive results, but without heart, fulfillment is missing. Only when all three are present do we create the purpose, engagement, and success needed for individuals, teams, and the wider organisation. Next slide, please. And culture and values were embedded throughout. We used inclusive feedback loops and aligned the app with our wellbeing goals. Innovation succeeded because digital, governance, and workforce teams worked together. My staff app became more than a tool. It became a platform for improvement. It's a model for how trusts can modernise our operations while supporting staff wellbeing and patient care. Next slide, please. Thank you for your time and interest. We are proud to share our learning and welcome further discussion. Please reach out if you'd like to explore My Staff app or the implementation strategies. Together, we can build a workforce ready for the future. I now hand over to my colleague, Julia. Thank you.
Hi, good afternoon, everyone. Thank you. And it's been fascinating listening to everyone so far. I think there's some real resonance for me around what Brian talked about, and then Ian, and also what Sarah's just described. So if we just move on to the next slide, please. I'm going to talk a little bit about innovation and transformation at the Yorkshire Ambulance Service. So just for a little bit of context, I am the Associate Chief Operating Officer. I look after the contact centres, so that's 999 and 111. And we're undergoing, like all elements of the health and social care system, significant transformation and change. Looking at how we build a future state to create high quality care, to improve outcomes, and a workforce that can deliver that, but are the best they can be as well within that. And that's our challenge. And I'm going to talk a little bit about one small element of quite a large transformation change that we're about 20 months into. How we're undertaking that at YAS, how we're working with our system partners. But I think I probably just want to land the notion of the change that I'm going to describe, the transactional piece that we are doing, or a part of a number of things that we are doing to transform, isn't where the change will come from. It's a tool for change, and I think it's really important to look at all the things I'm going to describe through that lens, because all of the other stuff that comes from it, so everything that Sarah's just described, not the what but the how, is where you see success and results in my experience. So if we just move on to the next slide, I've done a very brief who am I? So I'm a nurse by background, did lots of things in a kind of nursing clinically space, and then I stepped into more of a kind of leadership and operations function into transformation, and then worked in hospitals, and I joined the Yorkshire Ambulance Service back. I had my interview actually this week, 2 years ago. So I joined, I landed in February 2023, as we became a new directorate with a new role as an associate Q for remote patient care, which, as I've said, is the 999 and 111 service lines, covering the whole of Yorkshire. So if we just move on to the next slide, please. Thank you. So I'm going to talk to you about one element of a sort of 5-year plan on how we transform our services to be agile to the needs of the communities, to work in more synergized, healthier ecosystem of health and social care. We all know we have probably experienced, or our family members, loved ones have experienced very siloed health and social care and all that the impacts of that. So the kind of year one plan for us at Yas was just getting the foundations right. So we did a lot of work on our structure. And the last year we've been working on how we move from a dispatch model to a triage model for our 999 contact center. So when you ring or anybody rings and that first contact was run through a system, it's very, very protocolized. They are band 3 call handlers of following a protocolized system using keywords, etc. So that for 30 plus years had been a dispatch model. So it just was a crude tool to define how quickly somebody needed an ambulance. And we all know that healthcare has changed significantly in that period, and even in the last 5 years in reality. So what the organisation decided to do, pretty much around the time I was landing, was invest quite significantly, as you can see, in a different system. So we would triage as opposed to just decide yes or no to an ambulance. So really get into the detail around the symptoms and drive an outcome that potentially wasn't just about whether or not you got an ambulance, it was whether or not you needed to go and see the dentist or the out-of-hours GP or primary care, or you did in fact need an ambulance or an emergency department or an SDEC or something else. There's some real tangible benefits, because other trusts have done this before us, around how you get sort of patient cohorts into the right pot, I'm going to call it. So if you think about it through the lens of, so what does that mean from a patient centricness? It means that if you imagine if everybody is an emergency, if everybody's a Cat 1, no one's a Cat 1, because you cannot get to them quick enough because you just don't have enough resource. So if we can use our triage tool to ensure that we know that the most highest priority get the most highest priority, and then our assessment, our triage assessment, allows us to drill into how urgent or emergent that need is, we will ensure that we get the right outcome for patients. So that was a significant shift. So it wasn't about implementing the tool, it was about how we transformed the whole mindset, culture and vision that our teams worked within to shift from this dispatch notion to a triage notion, and how we get people who need either emergency, urgent or less urgent care at the earliest point in their journey. And that is the transformation, and that's a building block for future pieces of work that will get us to that kind of future state strategic intent that we are building, co-producing and designing. I'm just going to bob it on to the next slide, please. So enablers, I think Mark articulated it really well, so I'm really not going to label it. The PMO, so project management office, if you like, all that suite of knowledge, skill, support is absolutely invaluable, and we wouldn't have been able to deliver our change, our project change. So we have gone live now. We no longer take calls, 999 calls on our old system as of October this year. We had a period of implementation, which was over months, where we double ran to ensure we could train all of our staff safely, support them, nurture them, mentor them. It was a huge shift, and there was an emotional attachment to that shift for our teams that we needed to navigate. So having absolute clarity, oversight and everything covered within that sort of project management suite of activities, skills, knowledge, we wouldn't be where we are now without it. So I think 100% enabler for us. I think that sitting alongside, and again Mark really eloquently put this, alongside your SME, your specialist teams, their leadership and that PMO knowledge and skill and everything that comes with it are the reasons we've been able to go live on time, on budget and safely. that's not to say there wasn't times where it didn't feel incredibly challenging, and the teams have needed a significant amount of work and support to get us there. In fact, I've spent the whole morning in a culture session about how we're going to move forward and what's next for us, because in undertaking this transformation, it's unearthed lots of more work for us, which we knew it would, but you have to go through it to get there. So I think it's really important to kind of acknowledge that, and I think clear vision on why, and reiterating that because it was a painful process for some of our staff, and how we understood that and heard that from them was really important, and utilizing that constant learning. So we have had so many learning debrief sessions after each go live, in between, since, what do we know now, where are we going, just to give credence to build that culture of just and learning, and how we embed that, because that wouldn't have been the culture prior to this transformation, and probably prior to 2023, and that focus on successes, failure, this notion of failure, getting it wrong and trying to move on from that. And I'm just going to say absolute tenacity, because it's extremely hard to get anything done, to maintain BAU, keep the, I'm going to say, wheels on the bus, because it's constant. Even now I'm kind of seeing things flashing up in the bottom corner around just the operational position and the challenge that presents, while maintaining that. How are we going to continue with the activities we need to be where we need to be in 5 years, to be where we need to be in 10 years, to deliver that 10-year plan? Because if we don't do that, then we're missing a trick for both our communities who we serve and our staff. So that is a real challenge and a constant, I'm going to say, rub, but also allows us, it keeps the mind focused. So I'm going to say tenacity, and with a capital T, and probably all the letters capital in fact, for us to maintain that focus.
I love that, with a capital T, tenacity. I'm going to probably draw us to a close. I just think, Mark, Sarah, Julia, what amazing examples across a wide spectrum. Thank you very much for sharing. I know that there are questions, so thank you everyone who's asked a question so far. But before I invite those questions, we are absolutely privileged to have an icon in leadership, a veteran of the NHS, and an all-round amazing person with us today. Can I introduce Professor Ian Abts and ask for his reflections, both on the context of where we are, but also on some of the examples that have been so generously shared with us today. Ian.
Well, thanks very much, Anna, for that introduction. It's great to be with all colleagues this afternoon. So, as I said, I'm stepped down after the Chief Executive Guy Thompson for that. Really interested.
So I'm just conscious, Ian, that your sound isn't entirely clear. That might just be me. Let's see. No, okay. We want to hear your pearls of wisdom. So I'm going to get you to lean in and see if we can turn volumes up in various places. Let's try again.
Don't hear me, Nana?
A wee bit better.
Yeah. Okay. Well, I'll try and talk. So just a couple of observations really over the next sort of 5 minutes, if I may. Some general observations first, as I think everyone on this call will know and will promote, but I think we've got to get the why innovate story loudly out there, because fundamentally the equations in all high GDP economies that have sustained healthcare, certainly since the end of the Second War, are no longer stable. Healthcare demand is not currently being met by supply in many countries across the world. And the outcomes of care, despite the usual factors of supply, money and people, increasing over time, despite that, we are no longer able to sustain that equation. So if we are going to sustain high quality healthcare for all, we have to innovate. We have to do things differently. And I probably, at the moment, I think we're probably not loud enough on the fragility of those equations at present. There is more than a burning platform change, and we've got to make that case. I think the second thing is that we are, in some ways, in the health service, we're not broken, but we are bound. We are making change and innovative change in many places, everywhere at once. But I think the question is, how systematized is that, and how can we ensure that we spread good practice rapidly? One of the comments I think in the questions then was, we tend to be point solutions spread slowly. We have to change that model. There are multiple opportunities, some of which have come out on this call, particularly around operational processes that I think we would all agree have essentially been unchanged in many places for many years. The models, the operational models that we use, I still find it interesting that we still call something outpatients and still have a model that's basically been around since the late Victorian period, and not really questioned why we are doing it. And then clearly there are there are opportunities to change clinical models, but also clinical pathways based upon innovations, which are not just med tech, but also data-driven and biomed. So there are fantastic opportunities. I spent some time, Nena and colleagues, chairing the working group on innovation, adoption, and spread with Dominic Dodd for the feed into the 10-year plan and the life sciences sector plan. So if colleagues have had an opportunity to read those documents, within there are some suggestions about what we need to do. But I suspect it's actually many of the issues that we need to address are systemic rather than issues, for example, of personal appetite to change. But for example, we have to have a conversation about risk appetite. At the moment, the very easy to say no to doing something new based on some perception of risk. But are we really being honest about the risk that we all are holding at the moment, and that our patients hold, and that the systems hold? There are many risks in the current system, and going into the future, it's a balance of risk argument rather than an absolute. So I think we need a conversation about risk appetite. We need a conversation. We have a very high friction system for innovation adoption. It's partly to do with risk, but for example, data governance, procurement models, passporting, the death by pilot that we often put companies through. So we have to change the friction model. We have to go from a very high friction to a low friction system, and we have to do some experiments. The NHS has been the birthplace of experimental medicine in the world, but we are not yet able to do experimental innovation probably in the way that we need to if we're going to do it at scale. And the WHO are the people on this call, but we need to try. It's hard, but I'll be very interested in the research from York and Health Foundation on how much discretionary effort do colleagues across the health system have to actually innovate. And I think one of the issues at the moment is it's just very difficult to find enough aggregate discretionary effort to try and do something in parallel to the current process. And we've got to find ways of fixing that. And I'll stop now, Nena, but I mean, if not now, when? And if not in our great NHS, where? Because the NHS is not broken, but we've got, and the only way that we'll stop it being bowed is if we adopt innovation at scale quickly. Thank you, Nena.
You really important points there. The friction in our system, our risk appetite, the why. And I really like the bit around if not now, then when, because doing nothing is a risk in and of itself. Thank you, guys. There's some amazing questions, and I'm going to enjoy putting this to our panelists today. I would like to start off with something from Stephen Black. And it's a really good reminder that often when we use the word innovation, we think about shiny new toys. So Stephen puts the question to us. It's really good to see the definition of innovation includes process and governance. But what about the wider NHS debate that makes a serious error in equating innovation with new and shiny toys? So how do we change that whole perception and discussion around innovation? I might pause this initially. Who wants to go first? You're all nodding at me very sagely. Let me go with Brian.
It is a fundamental question, isn't it? And, and I think this language matters so much in healthcare, doesn't it? And there is that kind of the focus on innovation purely as being a tech issue does us a huge disservice, given this fundamental issue around improving processes, improving systems, the fundamental building blocks of how any kind of service works. And if we lose sight of that, we're in trouble, I think. I'd also think there's just a wider point about how we kind of use the change resources within the health system, because there is a challenge, I think, with, we already have a sort of a relatively small amount of resource dedicated to change. But if we think about innovation in a silo, if we think about improvement in a silo, if we think about kind of cost improvement, if we think about all of these issues separately rather than together, and how we kind of create the balance between them, then I think there's kind of, we create duplication, we create delay, we create kind of conflict between the things, and we lose the sight of kind of the ultimate thing is like, how do we create that balance between what we're doing today, today's business, and future business? So yeah, definitions matter. And if we lose sight of the basic fundamental issues, I think then everything we want to do in the 10-year plan is in jeopardy, I think. So really good question.
Thank
I'm
you.
sure Ian and others have got some thoughts on that too.
I'm just going to check around my panel. Nobody's nodding at me too vigorously. I just want to invite another question whilst we have the time to do so. There's a really wonderful question from Kerry, and Kerry, I think this is the nub of it, isn't it? It was really interesting that the change at MPFT might have been facilitated by the fact that we had really stable leadership. If we look at where we are in the NHS, I would describe this as VUCA times. And in VUCA times, leadership is not always stable, but some of these fundamentals being applied consistently and with tenacity, how do we do that in the face of not necessarily stable leadership? I am going to put that possibly to yourself, Mark.
Thanks. So I did see Kerry's question. I was trying to think of a good answer, trying to articulate my thoughts into that. But I think my understanding is Neil, our CEO, has been in place for a long time, as a number of the other senior leaders, although I've only been in MPFT for 5 years. Well, I think one of the things that I'm reflecting on from Kerry's question, but then from some of the others, is I think that there is definitely something around that stability of leadership, those connections people are able to develop, that relationship he's able to put in place with his staff, and that kind of safety, psychological safety, that ability to create a culture where people feel like it's okay to be innovative. I think Ian made some points about risk appetite, and I think one of the things that I've picked up from MPFT and then listening to colleagues in other organisations is sometimes that willingness to take a risk to try something new isn't always in place, but I think it probably is within MPFT. And I think that's kind of highlighted with our work with kind of other partners, but then also the kind of desire to try things differently. As long as patients are put at the heart of things, if you can try something different, you can evidence it's safe. I think that's something which has been supported, and that's certainly been the approach we've taken in terms of the development of our project management development program. We didn't have to do that. It was something new, it was something risky, could take up a lot of time, but there's the willingness to try something new. And I think that probably comes from the stability, the relationships, the culture that's been built up. And if it was the case that we were constantly changing CEOs, senior leaders, those relationships probably wouldn't be in place, and there'd probably be less of that willingness to try something new because we've focused on that continuous change at the top. So I think there is something around that.
Thank you. I'm going to bring Ian in because I think you guys had the advantage of that beautiful sort of the fertilized soil that was ready and receptive. But Ian, that's not the world we're going to live in now for the next few years, I anticipate. So what from your years of leadership and supporting managers would you say needs to be different now, even where it's patient centric and even where the case for change is strong?
I think that one thing that we probably need to decide on is what are a number, perhaps a small number, of fundamental changes that we may need through innovation. And we need to adopt either new processes, because I don't think it is all about technology, much of it is about process, and do it at scale. For example, and I think this is a massive opportunity for the shift into population health, having as part of Guidance and St Thomas's had the pleasure of actually providing community services for patients since 2009. There is good evidence, isn't there, that the care navigation for high risk, high resource, top 15% cohorts within populations ultimately gives better outcomes and experience for patients and saves money. And we all know how much money is spent, for example, in the health system when care navigation and admission occurs into acute trust. So how do we functionally and structurally design a system that is patient aware, but has an ambition to reduce through care navigation high risk patient presentations to ED by, let's call it 50%. Now, what I think the other issue there, Nena, is there may be 1,000 ways, but we would be better to choose 5. We suffer in some way, and this is true across the landscape really, of 10,000 flowers blooming means you can't focus on 5.
Yeah.
And I think we need to make some choices around where do we think the returns for our patient will be highest, and what do we think? And there's a big role, for example, for university and health systems to look at innovation assessment. Where do we think there's some evidence behind interventions which may not be technological, they may again be processed, that work, and then scale them? And we have to sort of think about the incentives for that. But I do think there probably are areas where if we scaled some of the interventions that we know that work well, we might regain a little bit of headroom then to start thinking about more broadly. That's how I would address it.
Thank you. I'm going to do a few rapid fire questions just to get a few voices in. I know we're running out of time and I could do this all day. I love this debate. I love this discussion. So firstly, Sarah, if I can go to you, and it's really just, I'm weaving in a few questions here. The difference between the process of change, and we can talk about how that dovetails or not with improvement methodology, Prince methodology, whatever we choose to use, and the importance of the emotional change. I think you picked that up quite a lot when you were talking about the readiness of your people. Is there a significant gap? How do we bridge it, and how do we make sure both are brought together?
Absolutely. And it does dovetail. And when I look at the 5 years that we have been in a development partnership, the concept came from staff. So they were engaged right from the concept. I've worked in the NHS over 40 years now, and we constantly work in silos. And what Ian was saying is, how do we scale up? Where is that bridge of communication? Yes, we've got the 10-year workforce plan, yes, and we've ticked the box there. So we're constantly looking at and that engagement. Where are the issues? And the issues at the heart of any organization. Very often with products, that are vanilla versions off the shelf, they don't tick the box, do they? And when they're implemented, people say, well, it's not doing what we want it to do. But this is what you've got. Whereas with My Staff app, it was built from the concept, from an issue that staff had that we addressed. And today, to have 100% engagement is phenomenal. But from the back end, through all these efficiencies that we've made, it enabled us to then further develop the app to what it is today. And the policies and guidelines module is just one module of many with the app. But in terms of that management style, the coaching style, but also that heart and that soul has been absolutely imperative to have. So thank you.
Thank you, Sarah. I'm going to ask both Lucas and Ian the question around, fundamentally, we spent a lot of time today talking about managers and actually the core processes and the core people who really make things happen. But people sometimes use managers and leaders interchangeably, and we all fall into that habit. Is there a distinction? Is there not? What do we want to say about that? So if I can get both your opinions, it'd be great to hear from you.
Ian, do you want to go first or do you want me to go first?
Why don't you go for it? You've got the mic.
Okay, fantastic. So I think definitely leadership and management are not interchangeable, but they are very closely linked. I think when it comes to the way we do leadership and management training within the NHS, we tend to talk about leadership and management in very separate ways. So when you look, for example, at the Edward Jenner program, there's a lot of talk about leadership is the vision, management is the delivery in sort of very broad terms. But I think the problem is that you can't really have that kind of artificial separation between the two, because if you're a manager but you don't have leadership skills, it's going to be very difficult for you to deliver on your job. So I think we shouldn't be using them interchangeably. We should understand what the definitions are, but equally we shouldn't be introducing that artificial division that you can be a leader and not be a manager, or vice versa.
Thank you. Ian.
Yes, thanks.
Sorry. Oh,
Okay.
I did mean the other Ian. I should be really clear. Too many Ians on one call. Ian Kirkpatrick, over to you.
Yeah, thank you. Too many Ians in the mix. I'm sympathetic with what Lukasz says. I guess I've been brought up on reading Henry Mintzberg, who once said that when I hear the distinction between leaders and managers, I reach for my revolver. But I can essentially I take the view that management without leadership is pretty meaningless anyway. That management is essentially a craft, and it should embrace that dimension of being able to lead. That said, formally speaking, managers might be people who have some position-based authority in the organization, even if it's just even if it's a band 6 nurse supervising staff in a ward. Leaders could potentially be people who don't have that position-based authority, but are nevertheless influential and will participate in change initiatives. So I think we have to hold on to the idea that you can have leaders who are not managers, but for all intents and purposes, I see the two terms essentially interrelated and inseparable.
I love that. Okay, so I'm going to put the Venn diagram. They are interrelated, inseparable. They are complementary, but necessarily separate, and they are entirely separate. And I think we've heard all of the above today. Would you mind, Julia, just maybe giving us your final thoughts on sustainability and cross-agency or partnership change in terms of the improvements you've made? How do we make sure they're sustainable, particularly in a wider system?
Yeah, no, absolutely. So I think the key to sustainability is bringing everyone on the journey. So it's not about me, my leadership, or any one team or any one member. It's how we instill the notion and the capacity and the development to understand why we're doing what we're doing and pass the baton on. I think was a really big part in culture and how we build really sustainable cultures to work within that are healthy and highly compassionate, even under significant pressure. Is the key to sustainability, because it will feel psychologically safe to be innovative, to have ideas, to try something new, because we need to, because that's where we are, as Ian and everybody's really eloquently described. And then I think how we work in a much less siloed, how do we plan to be less siloed as a health and care ecosystem, I'm going to say, to deliver some of this, because the reality is we can't keep doing it in the way we are doing it. It's not serving us, it's not serving our patients. So how do we do that together in a much more grown-up way and have that conversation where I, as a leader of an ambulance service, I'm not going to be fragile to the notion that my power changes if I work in partnership with an acute trust or a health or a social care, because it's not about that. It's about how we deliver it together and really start to frame that as a different way of thinking, and break down some of those barriers that are constructed by power or finance or commissioning streams, and that's a really hard conversation, but I think that's how we'll change and transform.
Thank you very much. So we are at time, and I'm going to invite Ian Abs to give us three, and I put 2 P's instead of 2 B's, look at me, to give us 3 key words to bring us to a close today.
Oh, thank you very much, Nana. I think 3 words are purpose, precision of delivery, and persistence of effort.
Love that. Thank you very much. Thank you very much. Listen, again, I will end by saying our managers are core. They should be cherished. The things we do, whether they're process-based, people-based, they're probably complementary more than anything else. This is our moment in time. Inactivity, indecision is not for where we are now. I'm really looking forward to the research that gives us the substrate to have these conversations in better detail, and to the broadening of innovation in our management community over time. So thank you all, and thank you to the Health Foundation for sponsoring this talk today. I look forward to all that comes out of this. Take care.